Hi, Sam. Sam, Sarah. Sarah or Sam? Could be either. Hi, guys. Oh, Leda. Hi, Lorraine. Oh, thanks, everyone. I've seen lots of the same names from Titty Gritty, so thanks so much for coming across. Michelle, I hope you're going to bring something practical to the table this evening. I know sometimes you like to joke around. I'm joking. Hi, Mel. Oh, yeah, I did it. Need to. It's Sam. Because it says Sam, Sarah. Hi, everybody. Right, in a moment, Dr. Annice is going to join us. And you know what? I haven't really planned this out very much. I'm just going to talk about the things that I found difficult, but I just wonder if anybody else wants to pitch in with areas that they've found difficult. Let's have a look. View request. Hello, Noodles Helena. Oh, Dr. Annice. Oh, it's so lovely to see you.
Oh, it's really yeah.
I look very bright on here. I'm just going to turn my little lamp down. Oh, it's so bright.
My dim because I'm in my sitting room because the internet's terrible in my office and Instagram doesn't work. So I'm
oh my God,
in my armchair.
I was glad that we didn't do this last night, right?
I know.
All when what even happened? But I've got to say, I don't know if anybody else felt it. I was like, oh, I feel quite. It's like a meeting of being cancelled that you know in your diary, and you're like, oh, what do I do with myself now?
Oh, I loved it.
It was actually quite.
Never get
it was
that.
actually quite nice. Yeah. So I was just saying, Dr. Annice, that I haven't really planned this out very much. I thought if you're happy, we'll keep it like a very sort of fluid conversation, and whether anybody wants to chip in. But what I was just saying a moment ago was that kind of coming through a breast cancer journey, like we both have. So if anybody doesn't know, Dr. Annice, you also went through a breast cancer diagnosis and treatment and everything. And it's that bit afterwards when you're kind of like signed off from the oncologist and you have your last bit of radiotherapy and it's or chemo or whatever treatment it is that you've had, and it's like, what now? And I put on Instagram earlier today that for me I felt like the shell of a person that I was before, but I wasn't also sure if I wanted to be that person that I was before. I knew that I wanted this to create some sort of positive change, and I felt physically drained, emotionally battered. Is that a very sort of normal feeling, would you say? Or
Yeah, I mean, I think it is normal. I think it's a big thing going through any sort of cancer diagnosis, and the treatments are tough. And if you're young and you're in the middle of your busy phase of life, everything stops, actually, doesn't it? Normal stops for you. And I felt like it was like being I always described it was like being in an international transit lounge far away, waiting for a flight connection. You don't relate to anyone and you don't quite know where it's going to go, and it takes time to during and after your treatment to achieve the belief that you can build your life back up again very rapidly. Yeah. And then questions are, do you want to build it up the same as it was before? Do you want to change things about your life? It's very reflective, I think. It's a very reflective time. And it was, for me, I mean, your audience may not know me, but for me it was 10 years ago. I had my 10-year anniversary in the summer, and I think it really was, it sounds a terrible thing to say, but having got through it, thankfully, and I know not everyone does, but having got through it, it was a really enriching and positive thing in retrospect. And that it sounds awful to say that, but ever since then, I've realized I need to live every day. I need to live in the moment. I can't worry and catastrophize about what's going to happen, because anything can happen to anybody. And I think, also, not suffering fools, sticking to sort of friendships and things that are really meaningful, work, everything. I think it does change your perceptions in many respects. But I mean, the other thing that I want to say, I mean, we wanted to talk about life after cancer and the good things about that. There are so many, because for me also it was about, you know, I wanted to see my kids grow up. I wanted to do everything I can to keep healthy, not just to prevent a breast cancer recurrence, but to have, you know, a really healthy rest of my life, to keep fit and strong, you know, to have healthy bones, to keep my heart healthy. So all of those things have kind of influenced me. I'm now obsessed with exercise. So I love it. I love my exercise.
Do you?
So, you know, empowering. And I know that a lot of women struggle with fatigue, and I'm actually, you probably don't know this, but I ran a regional and national fatigue management service in my NHS hospital when I worked in the NHS.
Right.
So really major interest in fatigue, and I'd see, as well as actually managing hormone problems in cancer survivors. So, you know, in a way, I was incredibly lucky because I knew about all of this. It still made that initial journey hard. I don't think anyone can be prepared for going through the diagnosis. But I think, say for the fatigue side, I understood sort of things. I talk about them like hacks, lifestyle hacks that I talk about in the book that I wrote about menopause. But fatigue, you can sort of sit on the sofa and just think, I haven't got the energy to do anything. But when you actually do something, as long as you
You're
don't,
energized,
you feel better. So doing nothing burns away at your energy, and moving, as long as you don't overdo it, it actually energizes you. So, you know, I think I knew a lot of those things that I needed to do really from early on. I remember when I had my lymph nodes removed from my arm and my surgery, and I couldn't move my arm at all. And I thought, but I can walk, it's great. So I used to go out and get exercise, you know, not long walks because I got tired, but little walks and things like that. But right from the very beginning, I knew that that was going to help. And I think we've all got to find our own way of building back up. We are all different. Not everybody's the same. But I think there are little things that you sort of need to know about that can really make a difference. I mean, actually, I don't know, Helen, how far out you are. You've still had recent treatment, have you? Have you had reconstruction?
I had my reconstruction done about 10 weeks ago now.
Yeah. And
so,
is that now?
Yeah, that's all done now. But I think up until that point, I sort of always had it hanging over me that I'm still in the system, and still, you know, I do feel a little bit more like I've been signed off now.
Yeah.
And it's a really great feeling.
Yeah.
I was very nervous that I wasn't going to enjoy this part, but actually I am, and I'm embracing it more than I thought I would. But I have to say, the fatigue thing for me is just been excruciating. It's to the point where I almost have to reschedule. I have to schedule my diary to make sure that I can get those daily nana naps in.
Really?
And because if I don't, I could I honestly think I could fall asleep standing up.
Yeah.
Like I only need 20 minutes, and then I shoot on again, and it's fine. And it's funny because I do exercise, you know, but yeah, it just really, really affects me.
Yeah, fatigue is very, very, it's a really tricky one because it's a symptom of so many different things.
Yeah.
So if you've got fatigue and you're doing all the right sort of lifestyle things, you really need to think about what could it be? I mean, things like stress can worsen fatigue. If you're even things like overtraining. I mean, I see people who say, I'm doing loads of exercise.
Oh, I'm definitely not overtraining.
You're not overtraining?
No, it's definitely not that.
That can happen. Poor sleep fragmentation, and difficulty with nighttime sleep.
Sleep so well.
Vitamin and mineral deficiencies, you know, if you're anemic, things like that.
Yeah.
And then there are sort of additional sort of medical type things that can, but usually if you've got quite marked tiredness, if you go to your doctor and get a panel of tests, if they're all fine, it's probably not, you know, one single thing. It's often multifactorial.
Do you know, I am going to do that. Charlotte's just said that fatigue is a whopper. It absolutely is. And Mrs. TP's saying 8 years on from diagnosis and still feel knackered. It's so, I feel like I hear it quite a lot. But then also, could that be the fact that a lot of us are put into an induced sort of menopause, and does menopause make those symptoms?
Well, it can do, but I guess for me, I went into an early menopause, but because I'd managed patients with menopausal symptoms, I helped them to sort of understand fatigue, but also just knowing about fatigue. What the other thing, menopause can cause fatigue, but actually in my clinics, both my fatigue clinics, my hormone clinics, fatigue is a really, really major symptom in the whole of society, because everybody chronic stress. In the pandemic, it's been really bad. Actually, sleep quality for everybody has been worsened. So there's just so many different factors that can, worsen fatigue. And so it is a problem.
It could be something else. Out of interest, was your cancer, if you don't mind me asking, were you hormone receptive?
Yeah, I was estrogen and progesterone positive, but I was HER2 negative, so I didn't get Herceptin.
Yeah. So how have you managed are you on Tamoxifen?
Well, I was on Tamoxifen for 10 years, and I was told that I got this really funny thing. You'd think if I was a doctor, I'd get like a little bit of, support. Well,
inside scoop.
Yeah. Well, I was 10 years out during last year it was this year in the pandemic. And I got a phone call from the breast nurse at my hospital clinic. And they said, "Oh, by the way, we're just ringing you to say you don't need follow-up anymore." And I went, "What? None at all?" And they said, "No, you don't need follow-up. You're 10 years, you don't need follow-up anymore, so we're discharging you." I think they said it's nothing to do with the pandemic, but I think they were struggling to get people in who were easy to, so they were trying to ditch off.
Get people out, right.
And I said, "Oh, but I'm on Tamoxifen and I haven't stopped it and I haven't had a review." And they just went, "No, you just stop it after 10 years. On your 10-year anniversary, you just stop it and you don't need review anymore."
Oh my God.
I did actually think, if I wasn't a doctor and I didn't know, how to navigate that would be quite a shocking conversation. Yeah. So I just literally stopped it. Actually, I waited 2 weeks till 2 weeks after my 10-year anniversary. And I stopped it. But I was on it for 10 years, yeah.
And was there any side effects coming off of it?
Yeah, so I was brilliant on Tamoxifen. I never had
What?
I know, and it's like Marmite Tamoxifen. I know people call it Tamoxicrap and all sorts of things.
I know, Tamoxibollocks.
Yeah, Tamoxifen some people just don't like it. I think the other problem is when you go on it, a lot of women go into menopause with the chemo, with the Tamoxifen, with the treatments they're having. And so it can be difficult to know what is causing what. But I never had any problems with it. And then when I stopped it, I was telling Sally the other day, because I think you saw Sally, didn't you?
Yeah, I did. Yeah.
I was having a chat. We went for a walk, and I was telling her that I came off it, and I do a lot of gym. I do a lot of strength training at the gym, and I have a particular weight size that I always use. And literally overnight, I started to ache, and I thought, "Oh, I'm getting injured."
Oh my goodness!
And I guess it's kind of it's funny, Tamoxifen, because it's an estrogen. It's a selective estrogen receptor modulator, so it blocks estrogen in breast cells, which is the whole point of the treatment. But it stimulates estrogen in, for example, bone, so it strengthens bone. And I could only think that it was the estrogen, the estrogen effects from the Tamoxifen in my bones or my muscles.
Wow.
But yeah, I was really achy, and I had to go down I didn't stop, but I had to go down on my weights. And then it took about 3 months for the symptoms to go away. It was really weird. And I've never heard that with from Tamoxifen, but I guess there's probably not many people who've had it for 10 years, because the studies suggesting that it might be helpful for 10 years have only around not very long. And a lot of women, they don't take it that long. So
gosh, that's really interesting, because it took me, I think, about 3 months of being on it before I feel like my symptoms and side effects settled slightly. But I know some people really hugely struggle with it. What's the other thing? Because I obviously, you were saying earlier that you do a lot of hormone treatment for cancer survivors. What are the other things that you get asked about a lot that might benefit some of the people listening now?
Yeah, so there are a few things. So if I don't just look after breast cancer survivors, it's all different types of cancer survivors. So and I worked in this field, you know, really heavily at cancer hospitals for many
Yeah.
years. So young women who go through chemotherapy for things like Hodgkin's disease and leukemia can often get damage to their ovaries and go into an early menopause from treatments. So, you know, I would support them with their treatments. But there's lots of other things that can be caused by various different cancer treatments. So, for example, radiotherapy to the brain, if somebody's had a brain tumor, can damage the main hormone glands in the brain. And so I would help people who have, you know, lacking those hormones because the radiotherapies damaged them,
Right.
help with management. And many chemotherapy treatments and other treatments can affect bone health and bone density. So I've got specialism in bones, osteoporosis, brittle bones.
Because that's associated with breast, isn't it?
Yes, well, there's a few things. Going into menopause or going into menopause early, it can cause bone loss, but actually tamoxifen strengthens bones, so it actually affects your bones. But in older women who have breast cancer treatment, they're often put on a group of drugs called aromatase inhibitors, Aromatase, or there's a few different ones, and they really worsen bone health. So they are usually a group of people who have scans and they have their bones checked regularly. And then sort of radiotherapy to the chest area, interestingly, it's not very common, but it can occur several years after radiotherapy to the breast. You can get effects that affect the neck, and in the neck there's two hormone glands. There's the thyroid gland, and then there's the thyroids, which actually control the calcium levels in the blood. So anyone who's had radiotherapy to the neck area, say if they've had Hodgkin's disease in the neck, like in lymphoma or something like that, and have radiotherapy, or if they've had a throat cancer or something like that, they can get damage to their thyroid gland, they can get damage to their parathyroids, and the parathyroid, most people haven't heard of parathyroids, but that's they control the calcium levels in your blood, and a high calcium, because actually the parathyroid, it causes it to go overactive, radiotherapy, causes it to go underactive. So actually a high calcium level is a complication of radiotherapy, and that calcium could cause aches and pains and fatigue and things like that. So actually it's called, the whole field of looking after people after cancer is called late effects. It was the brainchild of one of the consultants, professors I worked with and trained with when I was a junior doctor, and it's late hormone effects of cancer treatments, and there's loads of them. So brain, thyroid hormones, menopause, bone hormones, there's loads.
But why don't we know about that? Is it because there's not enough access to it? Is it a bit of a postcode thing? That
it absolutely is.
Because I would be, if there was somebody that lived near me that specialises, I'd be banging on their door. But also it's expensive because it's not, you can't get it on the NHS, can you?
Oh no, you can get it on the NHS, but
it's
everywhere. So my training in endocrinology, I did this big stint of research at our local cancer hospital, which is called the Christie Hospital in Manchester.
Yes, I hear so many good things about the Christie.
It's amazing. Hospital. So at that hospital, it was a pioneer centre for late effects, so all the hormone consequences of cancer. So my professor gave lectures all over the world on it, and it's well known. This isn't something wacky or weird, you know. This is a field of medicine, a whole field of endocrinology, and there are excellent centres through the UK. UCL is an amazing centre in London, and there's, you know, Cambridge and Oxford have good centres. Newcastle, there's several centres. Still a little bit patchy. So if you're not in one of the centres, you won't necessarily see that list. And I wish that it was more widely available. It really, and the big reason why it really needs to be, and this is a really good reason, but the reason it's not is because I think in the past everyone assumed that you died from cancer, and now
that's so true.
People survive long term and live long term late effects, as we call it, with consequences. So we really need to optimize quality of life in cancer
Yeah,
survival.
we do.
Hugely important.
Yeah, we do.
I wrote papers on this when I was doing my sort of MD. It's like a PhD research. It's a medical one. It's called an MD. And I wrote, my whole thesis was about quality of life in hormone related, a lot to do with cancer survivors. And it's hugely important. It really is, but it isn't, it's still a postcode lottery.
It is, like you say, it is hugely important, especially, well, no matter what age you are, whether you're young or old, quality of life is quality of life. Afterwards, you want to live it well, especially when you've been so stung by such an awful diagnosis and you've been through that, then you don't want to be living in the aftermath of it and just put up with it. Because I think a lot of us do that. Somebody just said earlier that she's 38, been through breast cancer treatment and completely lost her libido and worried that it's just not going to come back.
So if you through a cancer diagnosis and you've got any issues related to hormones, I feel really strongly that women, particularly when there's complex issues, should be seen by a hormone specialist like me who specializes in that, because it's not simple. It's not the same as somebody else just going through a natural menopause. It's more complex, and the treatments that you would need to be tailored very specifically.
Why is it more complex?
Well, because what you don't want to do is give a treatment that could increase the risk of a second cancer, because actually people who've had things like radiotherapy, I'm not saying we're more at risk of getting new cancers, but certain treatments can actually predispose years later to second primaries, different or even recurrent cancers. When I get a recurrence, that's very, very much more serious. So it has to be really managed very carefully, so that all the cons are taken into consideration. And interestingly, I gave a talk today for the Greater Manchester Cancer Network, and it was in alliance with Christie Hospital, because they'd asked me to talk about menopause and managing menopause in cancer survivors. And one of the things that I had spoken to them about was that I don't think women even get leaflets about menopause when they go in for their treatment. They don't get an information leaflet to say, look, you're going through cancer. These are your particular issues, and here's information. Here's where you can find more information. And it's that would be a fairly simple starting point, and then also for women to know that if they are really struggling, they can go and see one of these super specialists who will make sure that they get tailored treatment that's right for them. And like a bit like what you say with fatigue, there's so many things that can cause fatigue. Menopause can, but so can thyroid problems. So can
and I think when they do sort of sign you off and off you go, if there could be some information there about it, it would make you feel a little less alone as well, that that this is a thing, that you're not imagining it, that you're so I was saying earlier that yes, we're absolutely grateful, of course we are, to the oncologist that's got rid of the cancer, and so you don't want to appear ungrateful or but you do need that extra support still to help manage through this bit. So it's really interesting to talk to you, to know that these are options, that things that people can do.
Yeah, I think it is a real issue, because you see the oncologist and they're doing such an amazing job, that it's life-saving stuff. And I think a lot of women feel like they can't say, I feel really rubbish. And then got me through this, and you're saying my scans are good, or I've done really well. I'm not feeling great. And I've told them, I said, you have to ask the question. It's really important to ask the question about the menopause, and it's really important to be able to signpost them to signpost all women to safe resources. And so I am looking at actually writing some very specific leaflets, because there's lots of different issues, as you say. Some women will have issues. Some women will have fatigue as a main symptom, aches and pains, bone health, and not everyone gets everything, thankfully. But is that there's almost always lots of different treatments that you can will help with those symptoms. I really want to push for you know, I've called it late effects. Because for me, it's late effects. This is the consequences of cancer treatment. It's not a consequence of the cancer, because the cancer's thankfully mostly cured. It's the consequences of the treatment, and they're almost all hormone related. So not just menopause, all different hormones. So
and would this apply to people that are living with secondary breast cancer as well, or is that very different, the hormone situation there? Is that like a separate conversation almost?
It is really
a different leaflet.
Secondary breast cancer is a completely different thing. For example, you know, fatigue is a really major symptom for women with breast cancer, and it affects everyone differently, because it depends on where the secondary is. If you've got bone secondaries, obviously that's one thing. If you've got brain secondaries or lung, it depending on where the secondaries are, that will dictate what symptoms you've got. And often women with secondary breast cancer will need fairly regular intervention with their oncology team. So it's quite different. And then the other thing, we talk, you know, living well after cancer is, and I mentioned this about, you know, my own sort of journey, is that, you know, keeping well, you know, reduces your risk of getting secondary breast cancer. There's lots of lifestyle things, good nutrition, keeping a healthy weight, doing weight bearing exercise, you know, not smoking, not drinking too much alcohol. All of those things actually reduce the risk of secondary breast cancer very significantly.
Really?
You know, yes, absolutely.
Because I know that there's a stat that 1/3 of those with primary go on to develop secondary.
Right, there's lots so the problem with breast cancer is that it's a very it's devious, so it can lurk and hide, which is why women are given Tamoxifen and aromatase inhibitors for several years, because most cancers after 5 years you're cured. I don't want to sound negative, but most,
no, of course.
If you're and triple negative breast cancer, that's a different league as well. If you get 5 years, you're cured. Estrogen receptor positive breast cancers can sit and lurk for many years. So 99% of women who have straightforward primary breast cancer will live 5 years. So it's the 5 years is good. And then that goes down to maybe just under 90% at 10 years. And then the rest is actually late recurrences. So actually,
is that right? That's interesting.
Oh, yeah. Well, I wrote in my book, Olivia Newton-John got secondaries like 26 years after her primary. 26 or 27 years.
26 years?
Oh, yeah. Breast cancer is notorious. So I remember, because I worked as a junior doctor on a ward and saw all these sorts of things, women who got recurrent breast cancer many years later. So for me, what I wanted to do, I want to see my grandkids. I want to be old. I want to outlive my husband, who thinks he's universe. No, really mean. But you know, so I know that what you do now is going to protect you, not just for now, and not just help with your quality of life, but help with the long term. And exercise, nutrition, and weight, and not smoking, and not drinking too much alcohol. I do like a glass of wine. I'm going to hold
that was my next question to you, was like, do you like still live life a bit though, and have a drink every now and again? And
do I live life? Yes, I do. To be honest, my life, and you know, I feel like it's better than it was before my breast cancer. I worked way too hard when I was younger.
I feel the same.
Like lots of people, you know, you're juggling kids, career, everything, loads of different juggling things. And after my breast cancer, I realized I had to look after myself. So I have always since then prioritized, and it's not even a lot. And actually I'm better because I'm there for the kids, and I'm more around. Do I live life? Gosh, yes. I think the other thing that's hugely important is a social network. We all need a good social network, and I am absolutely blessed with the most amazing group of friends, friendship circles, and yes, we have a lot of fun. Sally Diniver is one of my very good friends. She may have told you about our crazy trips to Ibiza. You're never too old for these things. So we haven't obviously had a pandemic because it's been tricky, but no, I have a great time. And the other thing that I want to say is, although I love exercise, I like eating healthily, you know, and we all want to try and be healthy. I don't smoke, but we also have to live life. And
exactly.
No one's perfect.
Yeah.
I like a glass of fizz, you know, now and
Yeah,
again.
yeah.
Like my
And it's
food.
all those things in moderation and in balance. And
If you're conscious about it, you'll moderate more than if you just think nothing
yeah,
matters.
that's so true.
It really does matter. How you live your life matters. And, you know, it's not just those of us who've gone through a cancer diagnosis who need to keep ourselves healthy, because if we
Yeah.
all cause mortality and what's causing people to die as they get older,
Mm.
vascular disease is one of the really biggest problems, and that does link with poor lifestyle. It links with, you know, sometimes it's genetics, but if it's genetics, you can do things about it. There are medications
Yeah.
that you can take for things like cholesterol, but you know, regular moving 150 minutes of moderate intensity exercise a week reduces the risk of everything.
Right.
It reduces breast cancer recurrence by 55%, I think. But it reduces the risk of diabetes, heart disease, obesity, and several other cancers, actually.
Yeah.
So 150 minutes a week
So when you say 150, do you mean like going for a run, or could it be a
yes,
walk, a fast walk?
it can be a fast walk. I mean, you have to be a little bit out of breath, but you don't have to be doing mega high intensity training. In fact,
Mm.
I think a lot of women who go through the menopause with breast cancer, high intensity training is a danger, because you get injured and you don't
Yeah.
sustain. It has to be
Yeah.
sustainable.
What exercise do you do?
And I just have to say as well, I'll tell you about what exercise I do. It doesn't matter what anyone does, you've got to enjoy it, because if you don't enjoy it, you won't persevere with it. So
Yeah.
I love walking, and I love strength training. So I do a lot of gym, but I can't do it on my own because I'm lazy. So I have to go to class. So I have
Is that like a body pump sort of
yeah, like
thing?
pump and tone, and I have a great health club that I go to, and I have a fantastic trainer, and I go to all different classes anyway, but I have one trainer who's just hilarious and funny and entertaining, so I go in there. I'm looking forward to it because he's just funny and
Oh, that's so good to hear. But I think you're right. You have to find that thing that you enjoy
yeah.
doing.
But if you don't like pump or tone, or you don't like classes, don't do it. But you know,
Yeah.
all you actually need to do is brisk walking, and 150 minutes a week is 20 minutes a day.
Yeah,
And
it's nothing, isn't it? Yeah.
nothing.
And
And
it's just getting into that routine of doing it.
it's getting into the routine, and it takes 6 to 8 weeks for us to build a routine. But actually, you know, if you feel tired, walk slowly and build it up gradually to
Yeah.
being. But
Yeah.
it's really profound. And one thing that I always say to my patients is that, you know, how you could start with tiny little changes is basically 10 minutes walking instead of 10 minutes on social media, because a lot of people say, I haven't got time to do exercise. So okay, 10 minutes on a brisk walk outside instead of 10 minutes on social media. The health benefits, if you persevere,
Yeah.
are profound, and you're halfway,
Truly.
50 minutes almost. So that is really, really, I think, if I could help anyone with anything, and it helps fatigue, it
Yeah.
energizes you.
Yeah.
It doesn't. They've done studies on looking at women and men who are sitting and they're exhausted and they're tired and they're thinking, I don't want to do exercise, and they do a questionnaire that says, how do you feel now? I feel really tired. How do you think you'd feel if you went for a 20-minute brisk walk? And they go, I think I'd feel worse because I'm tired. So instinctively, we're telling
Mm.
ourselves for certain.
Mm.
And when they do the questionnaire, when they come back, they always feel either the same or better. Never worse.
Mm.
It's amazing.
It really, I'm completely with you on that. Sometimes I just find it really hard to get motivated, but we all go through that. Somebody made a really good comment at Sean. Before my diagnosis at 46, I was always a healthy weight, ate organic, exercised regularly, never smoked, drank very little, and still got breast cancer, which is very much like my story, actually. I was pretty fit and well, don't have any family history. Is there an element of just being a little bit unlucky?
Yeah. I mean, I'm exactly the same. I have no family history. I'm tiny. I'm like, you know, very skinny, never smoked in my life, always eaten healthily, always done exercise. The only thing I would say with me is I had a stressful job. That's the only thing I can think of that could possibly have linked, really.
Yeah.
But there is definitely a bit of unluckiness. But then the other thing, if you've already got a healthy lifestyle, is that, and no one, I mean, there's no guarantees in this world
No.
without. But if you have a healthy lifestyle already, and again, there's good data on this, looking at women before and after a breast cancer diagnosis and what their health is like, you have a much lower risk of recurrence. There's no guarantees, but you have a lower recurrence if you have all the already in place.
The other thing, and I don't know if you would agree, but my oncologist said to me that when I was given quite a robust health plan, treatment plan, he said the good thing is you're fit and well, like you'll cope with this a lot better if you were going to this into this unhealthy. That helps as well, you know.
Absolutely, because you can get through all the treatments. So I mean, it's nobody's fault if they're unhealthy before diagnosis. Everybody.
God, no. Yeah.
But if you're not as well, then it's more of a struggle to get through the treatment, and it's really, really hard. But yeah, I mean, it definitely helps to be in good shape prior to any sort of. I mean, isn't it?
Yeah.
I mean, chemotherapy. I went through chemical menopause and mastectomy and lymph node removal, but I didn't have to have chemotherapy. So I felt.
Okay.
In fact, actually, I was really upset that I didn't, because I wanted belt and braces treatment, because I knew.
Right.
A lot about
for
it.
the peace of mind almost. Yeah, I get that.
And I was 42, 41, so I was worried, but yeah, I didn't have it.
And do you have HRT, or is that not a route that you go down? No.
My cancer was estrogen receptor positive, progesterone receptor positive, and it was early stage, which means that it was early, but it was a slow growing tumor.
Right.
Told you about the risks of HRT and the risks of recurrence breast cancer. It can come many, many years later. So what if I took HRT? We know from a study that was done back in 2009 that 3 years of HRT with in a breast cancer, somebody who's had primary breast cancer, it very much statistically increases their risk of getting recurrent breast cancer. So for me, that data was quite clear. So I wouldn't choose to, because I might take it for 3 years or 5 years or 7 years, but my recurrence might come in 10 or 15.
And can I ask, when you say recurrent, does that mean breast cancer coming back in your breast, or does that mean secondary somewhere else in the body?
Well, it can be either, but
right. Okay.
It has a tiny rate of primary breast cancer, because we know it like being obese or smoking or not doing exercise, it does, so it could increase the risk of primary breast cancer in somebody who's already had breast cancer, because we don't know what else caused your breast cancer. You've obviously got, once you've had anything once, you're more likely to get it again. But it increases the risk of secondary breast cancer. So obviously, once you get secondary breast cancer, you are likely to not survive that, because that's what kills people. The secondary. Primary doesn't, thankfully, but once the secondary occurs, that is a different disease that's widespread, usually through the body.
The other thing I wanted to ask is, when you're given a diagnosis and you're estrogen and progesterone receptive, they grade you like. So I was 8 out of 8 on estrogen and 8 out of 8 on progesterone.
Oh yeah.
What does that actually mean? Does that mean I'm more hormonal?
It's a hormone. Oh no, it's nothing to do with you personally, but it's just, if that's cancer's formed, it means that it's very sensitive to estrogen. So it means if estrogen is around in your body, then those cells feed off estrogen. They feed off estrogen. But that's why tamoxifen and aromatase inhibitors are used. So tamoxifen is used in younger women, like you, I guess, who are pre or perimenopausal. Because what tamoxifen does is it starves the cancer of estrogen. So it blocks estrogen effects in breast cells and in breast cancer cells.
It's a really clever drug, isn't it?
It's a very clever drug. Yeah.
I know that a lot of us moan about it, but actually when you hear what it actually does and the fact that it helps strengthen your bones, and that, I'm actually, wow, this is amazing.
Well, it is
that
amazing.
We've got access to it.
And Sasha Howell, who is an oncologist at Christie Hospital, gave a talk as part of my talk. He was talking about preventing breast cancer. That's his interest in research and everything. And he was showing tables of women who have been at very high risk of breast cancer because they've maybe had, BRCA genes and different things. Right. I mean, that's a whole realm of oncology.
Yeah, yeah.
And that some of those women are given tamoxifen to prevent them getting breast cancer. And they're often given it for 5 years. And he showed tables of the rate of breast cancer in the women given tamoxifen versus placebo, which is they're given a sugar pill, and they don't. It's a blinded study, so the women don't know. They haven't got breast cancer, and they don't know whether they're getting tamoxifen
Wow.
or.
Yeah.
And they've been doing these studies for years, and it's dramatic because 5 years of tamoxifen, after 15 years, you can still see that the incidence of subsequent breast cancer is so much lower in those treated with tamoxifen.
Wow.
Compared with placebo. So it is actually a phenomenal drug. I mean, I know that some people can't take it, and it can have side effects, but it is a phenomenal drug because it reduces secondary breast cancer, you see, years later. So that's why it's being used for longer even now.
I'd be scared to come off of it. I'd want to keep taking it.
Yeah, I know. And I felt like that because I had it for 10 years. I think the data are 10 years for women. And the thing, I was just told to stop. And I think that the biggest risks or side effects with tamoxifen are two, really. One is blood clots, and that blood clots are only really, they're more of a risk if you're very overweight or if you have a family history or a personal history of blood clots. So if pregnancies and not had blood clots, it's less of a blood clot risk than the pill, actually.
Yeah. Is that right? Okay.
Similar risk of blood clots to tablet HRT. So it's not a massive risk, but it's there. You're overweight or have other risk factors for blood clots, then it can be risky. So I wasn't worried about that because I'm very, very physically active, don't have any history of blood clots. But the thing about tamoxifen is that as I said, it stimulates estrogen receptors in bone, so it strengthens bone. But it stimulates estrogen in the womb, so it can thicken the womb lining. So I think forever it can cause thickening, and then it can end up needing to have a hysterectomy and things like that. So that's kind of why I think they don't tend to recommend it forever. Some women are being recommended it, particularly if they've had a hysterectomy and they don't have a uterus, and if they don't have any risk factors for blood clots, they're being given it lifelong. You know.
Does your routine smear check your womb lining?
No, it doesn't. No. The only way you would get a womb lining check, you can do it via ultrasound. And they can do an internal ultrasound, which is fairly straightforward. Yeah. Usually only do that if you get unscheduled bleeding.
So because
if you've got
so again, that's something else to look out for. That's something that I've never been told.
Yeah.
God, so interesting.
You need to so if you get any unscheduled bleeding, you'd end up having an ultrasound, and you'd get a test called a hysteroscopy, where they put a little camera into your womb. So smear doesn't do it. It's an outpatient procedure. So I had years ago when I was on it was probably about my third year on tamoxifen, and I had this unexpected bleed which was very heavy, so I had it done, and they just check up, they go, no, there's no womb cancer, carry on, sort of thing. So but it can be alarming because I see a lot of people who get this unscheduled bleeding and they don't really understand why and what to do, and if you understanding things makes everything. And
oh my God, yes, it does. Yeah.
And the thing, just going back to fatigue, I mean, fatigue is multifactorial, but one of the things I see in patients who have recently gone through a cancer diagnosis is you're on high alert. Your stress hormones are on high alert because of what you've had to go through. And if you don't have the stress because you think, right, well, I know that's causing that, and I know that symptom doesn't matter, and I know that if I get a bleed, I know what to do. If you are empowered with that information, and actually it's with any medical condition, but I just more important in going through breast cancer diagnosis and, for example, menopause or other things at the same time, it's pretty tough. And if you understand it, it's easier. And I know that was because I dealt with all of this my entire career. The whole thing was less difficult and stressful, and that's
so much sense.
That's why I came onto social media, because I also I think people don't fear breast cancer now because so many women get breast cancer, but going through it's not the best.
It's really not. But actually, having chats like this it will help. I mean, it's helping me. It's going to help lots of people. It's getting that knowledge, and I love the fact that you're working on a leaflet with Lindsay. Is amazing.
Yeah. No, that's hopefully. I mean, it's always difficult to get these leaflets sort of adopted by the NHS hospitals. There is a lot of bureaucracy, so it's a lot of effort. We can do the work, and then but I've got a lot of cooperation from some of the key people in Greater Manchester Oncology. So I'm really hoping we can get them done quickly, and then get them everywhere, get them in all clinics.
Yeah.
Because it's
one bit of paper, it would help so much.
And the others don't have the time, and we know that they've got a busy job to do, but they're not. I said to them today, women survive breast cancer now, and their quality of life after breast cancer is really, really important, and it's responsibilities. It is the responsibilities to get these clinics. So so I think it's the good thing is this change is happening. People are recognizing that a lot of women struggle with menopause. Not just women who've gone through breast cancer on the, which is a good thing. But we need to with breast cancer survivors, we need to make sure that they are managed safely, and there are lots of unique things which it's taken my entire career to understand the complexities. Shouldn't
definitely been spoken about more, isn't it? I've got a question here. What about environmental changes, estrogen found in beauty creams and food and things? Is that?
It's a real concern, actually. I mean, I can't say that's nothing. We call it endocrine disruptors or hormone disruptors, and the problem is they're getting into food chains, and it's really difficult to it's really difficult to tangibly put your finger on a study that demonstrates the problem. So actually, we know that there's something called phthalates in plastics, for example. And so if you, for example, heat up a meal in plastic Tupperware in a microwave, well, one, it depletes all of the micronutrients. It stops you absorbing the micronutrients from the food. So it's not good to heat up in plastic anyway. You should heat up in glass. But these
my God, I didn't know that.
Yeah,
these just had a bolognese out of a. Oh God, okay, yeah.
They sell the products and they say these plastics are microwavable, but are they? They say that they're adequate, but so these chemicals in plastics can leach into the food, and there's been some amazing research done in America which looked, it's nothing to do with menopause or breast cancer, but it looked at baby boys being fed through tubes who were premature, plastic tubes. They were being fed, and the chemicals, the endocrine disruptors, were leaching from these plastic tubes.
Oh my God!
From the food, and there is a link, and they've demonstrated it very clearly in scientific research, that there is a link between that and fertility in later years, and gonadal development for those boys, the testes development. So that's some very specific research, but we know that endocrine disruptors can affect hormones in women and men. Who knows? You said you're unusual, I'm unusual. Maybe it's chemicals in plastics or something that had a contribution to our diagnoses. We don't know that, but it is a concern. So using things that are more natural, less chemical based throughout is really a big consideration, and I don't even know all the answers to that.
No, of course.
But I am aware that plastics are a danger. We know what it's doing to baby boys. What is it doing to adult women, or any of us? These endocrine disruptors are affecting fertility in adults, and they could be inducing. We know that hormone related cancers in general, so that's prostate cancer, other estrogen dependent cancers other than cancer, we know that they're on the increase, and our genes aren't any different. So it's environmental factors that are contributing, and it's finding out what.
Interesting. Lumux is asking, what about HRT with triple negative breast cancer, especially if on Zoladex?
So that is, it's it's a narrative answer, because obviously if you've had triple negative, have you had a double mastectomy? What, you know, everybody's different.
Yeah.
But when we look at all comers, what we know, and this was written very clearly in the British Menopause Society recent consensus, is that whilst the general danger that's perceived is with estrogen receptor cancers, because of the cancers feeding off estrogen and being blocked by tamoxifen, 8% of women, and I don't want to alarm anyone, but this is just the data that I know, you know, and I am a breast cancer survivor as well, but 8% of women with estrogen receptor, 8% of women with triple negative breast cancer have a second primary breast cancer. So not a secondary, but a second primary, which is estrogen receptor positive. So, you know, that links with the genetic reason. So many of those women will have.
Oh my goodness! So they've had a triple negative, but though 8% of those will have a recurrence in the same area, but that will be positive.
So that they would have a second primary, so another new cancer that was estrogen. 8%.
Right, but that is estrogen positive.
Yeah. And
wow.
Also a small group of women who have had estrogen negative, triple negative breast cancer actually get an estrogen receptor positive secondary, which we don't really understand why. So this is smaller numbers, but so
right. Gosh, that's so interesting. I didn't realise that it could flip like that.
It can flip. So that's why if decisions about hormone therapy need to be made really by the MDT, by the experts, it should not be a decision.
And it's a case-by-case thing.
I mean, I know women who've had double mastectomies, even hysterectomies, and because of their stats, they can and need to take HRT if they've had these treatments very young. But then there are others, and their stats would suggest that would be more dangerous. It's a sort of I don't want to say Russian roulette, but if it's not an informed decision, looking at all the information about that woman, it can be a inadvertent wrong decision. And you know, with HRT, we talk about this. I see a lot of women who are on HRT who still struggle with fatigue, who still struggle with aches and pains, who struggle with symptoms, or who get side effects.
It doesn't always,
always. Yeah, you know, it's not always the panacea.
Not always the wonder drug. Before I forget, what's your book called? If anybody wants to know.
Yeah, it's called The Complete Guide to the Menopause.
Right.
It's with Penguin. It's with Penguin Random House. So it's I should have brought a copy, shouldn't I? But it's bright red and yellow. I didn't choose the colour of the two. They choose it. But it's bright red and yellow. And basically, a lot of the book is all about the things that I talk about, which is, you know, about menopause, about what you can do for yourself, because actually all of the things that I tell my patients who've had breast cancer to do, I tell all my patients who are going on HRT as well. I say, look, hang on a minute, HRT is not a panacea, it doesn't suit everyone, and it might cause side effects, and it might not solve all of your problems, so you've got to do these lifestyle. Well, because, you know, also protecting your cardiovascular risk, protecting future breast cancer risk, everything. The things that you can do for yourself: stress management, sleep management, exercise, nutrition, and all of those things can really, really help.
Make a difference.
And then, you know, if a woman does then choose to go on HRT and she's tried all of those things, or if she's on HRT and she's doing all of those things, then outcomes are better overall. If you're using the lifestyle tweaks as well. But so in my book, I talk about my own journey as well. I talk about how I was a junior doctor when I was 23, and I worked at Christie Hospital, and I worked with lots of women who didn't have access to the amazing treatments we have today. I was, you know, and at that point, I talk about this in my book, but I'll tell you, because not everybody's going to buy my book, but I never for 1 second thought I would ever get breast cancer. I didn't have a family history. Oh, you know, these poor women, they're going through breast cancer, it must be awful, but that's never going to happen to me. And that's what people think. They think, I don't want to hear about it because it's never going to happen. And then roll on forward 23 years, so it was 93, 2003, 2000. So it was nearly 20 years later. And I got a breast cancer diagnosis myself, and I couldn't believe it. But I was so lucky, because nowadays the treatments are so much better than they were even in 90. 1983 when I was a junior doctor. So yeah, I mean, so I talk about my journey and about my thoughts, because it was coincidence that I'd specialized in late effects. I'd managed many women with breast cancer and how they managed menopause after breast cancer over so many years before I got my own diagnosis.
Gosh,
So
it is absolutely fascinating.
yeah,
Absolutely fascinating.
I think I'm very, very lucky, but I also know that with the right help, women can really get an life back on track, and live healthier because they're aware, because you know that it's important to prevent recurrence, to adopt healthy lifestyle approaches, because it absolutely does. It doesn't just prevent having a new breast cancer diagnosis to a lifestyle. It prevents recurrent breast cancer. It prevents second cancer. So it's really important. But yeah, living your best life, laughing. I always talk about this: downtime, self-care, laughing, social network. They are really important, and we don't value those things enough.
No. You know, and we need to carve more time out for that, I think, don't we? Especially now, you know, lockdown's lifting slightly. Get out there.
Last night I did think, oh, I've got a whole evening free. It's great.
Oh my God, don't you just love that when you've got a whole evening? Oh my goodness, it was dreamy.
Yeah, but I think
so I've got a dog scooting around underneath my chair. Oh God, I don't know what she's got. I'm going to have to just grab it off of her. I could hear she was eating something. Oh, it's all my expenses receipts.
Oh, this is your new puppy.
Yeah.
Thing, I'll tell you.
Monkey.
I've seen your new puppy on your feed. I mean, that is a stress reliever.
Hugely so. My goodness, amazing.
Yeah.
It really has helped me, actually. She makes me slow down a bit.
Yeah. And does she need walking? Because she's tiny at the moment.
No, she does. So I take her out 2 or 3 times a day. She's only 5 months.
You're getting exercise with the dog?
Yeah, exactly. Exactly. And just constantly running around after her. Oh, she's got
she's bigger. She's great.
Yeah, she's got a lot bigger. She's got a lot bigger. Well, listen, I can't thank you enough for taking the time out to talk to me and to just share all your knowledge. It's absolutely amazing. And I'm going to put a link up for if anybody's interested in Dr. Annice's menopause book, Complete Guide to the Menopause. It's just really great to know that there are options. Yeah, and I feel like I say it every time, but this is why, you know, doing stuff like this is so important, because I think that, you know, if we help one person on here, then we've done a good job today. Absolutely, definitely, and getting that word out about there's always solutions as well. Yeah, absolutely. Oh, I'd love to chat to you again, and any feedback from you guys that was listening, I'd really love to hear if there's any other subjects you want us to talk about another time. Yeah, it would just be great to hear from you. Oh, have a lovely evening, everybody. Take care. I'll see you soon. All right, take care. All right, take care. Bye.